Good evening or good afternoon, wherever you are. Hi, everybody. It's my pleasure to welcome you all to a new ESG webinar, this time focused on diagnosis and management of gastrointestinal neuroendocrine tumors, what every endoscopist needs to know in 2022. My name is Vicente Lorenzo Zúñiga. I am very pleased to be the moderator of this session, so thank you very much for the invitation. I am consultant on GI endoscopy and associate professor. I am based in Valencia at the University and Polytechnic Hospital of La Fe. And today we have the honor to have with us two well-known expertise, two well-known speakers, Ulrich Denzer and Dermot O'Toole. They are going to talk about diagnosis and management of gastrointestinal neuroendocrine tumors. Each presentation will take about 20 minutes. You can send your questions through the Q&A tool. So at the end, during the discussion period, we can answer the questions, all questions you have. Remember, this is for the 5th consecutive year. ESG offers the opportunity to view high-quality presentations, to interact with the speakers, to participate with online questions, and also to receive the CMA credits from the European Accreditation Council. This evening, you will receive an email with a link to the survey in order to receive your credits. Now, we're going to start with the first presentation. It's my pleasure to introduce you Dermot O'Toole. Dermot is a gastroenterologist consultant. He's a well-known speaker. He has a deep knowledge in this field. He's based in Dublin. He works at the St. Vincent University Hospital, St. James Hospital, and Trinity College. And he's going to talk about the role of endoscopy in diagnosis of gastrointestinal tumors. Now it's your turn. The floor is yours, Dermot.
Thank you very much, Vicente. And I'd also like to thank the ESGE for the opportunity to discuss this topic dear to my heart and what we're doing every day in the clinic. These are my interest disclosures. I have no conflict with the current presentation to my knowledge. So when we talk about gastrointestinal neuroendocrine tumors, we prefer to use the term neoplasm. We're talking about those that affect the gastrointestinal tract and not the pancreas here. And it's possible that we will look to give you a different presentation about neuroendocrine neoplasms of the pancreas, which is very interesting, and the therapy of that, which is more and more endoscopic now as well. So we might come back to you with another webinar with that in mind. Those of the gastrointestinal tract are fairly rare epithelial neoplasms with an increasing incidence. And in fact, NENs, in fact, arise mainly in the GI tract, and they represent up to 80% of all neuroendocrine neoplasms. Their behavior and management will vary according to different sites. And as I mentioned, neuroendocrine neoplasm is a preferred term to neuroendocrine tumor because it encompasses both well-differentiated neuroendocrine tumors and poorly differentiated neuroendocrine carcinomas, and they behave completely differently. And gastroenterologists, not only oncologists, but gastroenterologists need to be aware and appreciate the differences in terms of morphological, histological differences because the management is very much different. So NENs then are discussed at should be discussed at NEN-related multidisciplinary tumor boards, especially for complicated cases. And with that in mind, most of the people in Europe and many across the world will have affiliated Center of Excellence groups like the ENET Centers of Excellence. And I really do encourage you to link in with the tumor board that is specific to this. Another term that's important for the gastroenterologist is functional versus non-functional neuroendocrine neoplasm. When we say functional, it refers to overexpression of peptides or hormones causing a specific set of symptoms or clinical syndrome. For example, Zollinger-Ellison syndrome or gastronoma or carcinoid syndrome. And the non-functional ones are those that don't cause any specific related symptoms. So features common to all GIT NENs are that they affect both the mucosa and submucosa. And this is very important because even though small tumors might look like they're submucosal, in fact, when you take a biopsy, they're usually positive. And this is, of course, different to many other subepithelial lesions. There are several important differences in primaries from each site, and we'll see them as we go along. The pathological classification should be performed according to the UICC and the ENETS staging and grading system. The asymptomatic neuroendocrine tumors or neoplasms are incidentally found more and more, and they're very often seen at endoscopy or investigations for other reasons, especially applying to the stomach, the duodenum, pancreas, and rectum. And especially, of course, more and more often now as part of screening. And with that in mind, it's very often that the first biopsy is performed without beforehand knowledge of a NEN, and the increasing discovery of incidental NENs is causing that are not causing a specific set of symptoms, means that the gastroenterologist needs to be aware of their presence and indeed the challenges that they pose. So this is just a summary of the pathology for most GI NENs. And the first important thing is differentiation, the morphology. And on the one hand, we can distinguish well-differentiated neuroendocrine tumors in the first three columns, and on the right-hand side, this completely different, very aggressive, poorly differentiated neuroendocrine carcinoma, which represents, fortunately, only about 10 or 15% of cases. And the well-differentiated tumors can be subdivided into very well-behaving and moderately behaving based on tumor grade with a Ki-67 proliferative index. And different grades, of course, exist depending on the cutoff. And the other important thing for gastrointestinal tract tumors are tumor size. And again, as tumors tend to get bigger, they tend to behave in a more malignant manner, as outlined here. However, some small tumors in some sites can also behave in an aggressive manner, and awareness of this is important. Other particular features of neuroendocrine neoplasm, just to remind you, is that the vast majority of well-differentiated tumors express somatostatin receptors. So imaging is performed using somatostatin receptor scintigraphy, or more modern now is used PET-CT, such as gallium DOTA-TOC, DOTA-TATE, or DOTA-NOC PET-CT. And this really is a very good adjunct in terms of staging and allowing us then to go on perform endoscopic resection in the absence of lymph nodes, etc. And also to remind you that on the right-hand side of this slide, tumors are very often hypervascular, and this is how sometimes we pick them up on scan as well, as attested to here, one in the stomach on the right-hand side and one in the small intestine in the left-hand side. And this is one of the particularities of gastrointestinal neuroendocrine tumors of the GI tract. But this is a complex slide just to remind you that the sites that we're going to look at today are esophageal, gastric, duodenal, small intestine, and colorectal. I'm only going to mention esophageal here very briefly because in this slide, the vast majority of these are high-grade neuroendocrine carcinomas. 90% are small cell in type and 10% large cell with a high mitotic index and Ki-67, and they almost never are treated endoscopically, behaving very much like aggressive poorly differentiated adenocarcinomas or squamous cells, and are usually treated in that manner. We will spend some time on the gastric neuroendocrine tumors, which is a variable pathologies we'll see. Duodenal that can be functional or non-functional. Small intestinal ones, we'll mention those in colorectal then just at the end. Very recently, ENETS has just published last month, has elaborated a standardized endoscopy reporting system for neuroendocrine neoplasms because they're different from different types and different sites. And I will encourage you to have a look at this paper that's just been published, and it's free to download on the Journal of Neuroendocrinology. And we'll refer back to that in a moment. What endoscopic approach and assessment has been based on is the characterization of these neoplastic lesions. And we should make note of the anatomical location, other location landmarks, for example, in the stomach, be accurate about exactly where it is. The appearance of the lesion, of course, all of these things you know, whether it's round or nodular, polypoid, sessile, etc., ulcerated, hemorrhagic, its size, the number of lesions, which is very pertinent, especially for gastric NENs, and the shape of the lesion. The shape of the lesion will be performed using the Paris classification, of course, which is standard, and then characterization of the surrounding mucosa. And this is important, again, especially for gastric and sometimes other tumors. In addition to that recent paper, Professor Pierre Dupré also led a group and published recently an updated guideline in the ESGE series on endoscopic management of subepithelial lesions, including neuroendocrine neoplasms. And I'd encourage you to look at this as a very good paper and with some recommendations as well. And of course, we will hear this in the second part of the talk as well, where we're talking about therapy. But EOS is an important adjunct for GI neuroendocrine neoplasms, especially for in-between lesions or lesions that are approaching a centimeter or above, for accurate T staging and for end staging. And again, I would always encourage this, especially for duodenal and rectal and some of the gastric ones as well. I mean, these are tumors that involve the second and third layer for the endosonographer. They're hypoechoic or intermediate hypoechogenicity, sometimes hyperechoic. They're usually well-defined, and it's useful for stomach, bowel, rectum, but also for duodenum. So this, for example, is a patient with a small, 9 or 10 millimeter lesion in the duodenal bulb. It looks solitary, and you can see an endoscopic ultrasound here, very nicely demarcated within the mucosa and submucosa and the muscularis propria here. The black line is well outlined. The patient had peptic ulcer disease, recurrent peptic ulcer disease with an elevated gastrin. So the question that I ask you, could this be treated endoscopically? Well, from looking at this, you think yes, but if you know the biological behavior and the clues that I'm giving you that this is Zollinger-Ellison syndrome here, most likely, then you need to look a little bit harder. And when you look a little bit harder, just a little bit further down, you can see there's a lymph node here below the level of the tumor. So accurate local staging, and this is N, and this obviously requires surgery. So a knowledge of the actual biological behavior for some tumors like gastrinoma is important, not to make the error of thinking this is a non-functional, single isolated net where it can be treated endoscopically. Histology generally then is sufficient with standard biopsy because, as I mentioned, these tumors are both mucosal and sometimes submucosal, and very often both. So standard biopsy is usually sufficient, and we perform standard H&E, but we also stain for chromogranin A and synaptophysin, but especially chromogranin A for the well-differentiated tumors, and we perform a mitotic count with a Ki-67 index. For tumors then that will be resected, we also have in addition to a biopsy template, we've got a template for resected specimens, and with templates for pathology in neuroendocrine tumors have been recently published again online in the Journal of Neuroendocrinology. And some of you might find this useful to refer to. So if we then just wander into some of the various types of tumors that we encounter, firstly, gastric. So this is a frequent situation for us. 6-year-old fit gentleman with asymptomatic anemia, had a gastroscopy with a couple of small polyps that were less than 10 millimeters. The biopsy showed that it was a neuroendocrine tumor, it was chromogranin A positive, synaptophysin positive, and the Ki-67 was 7%. So in fact, what are the endoscopic appearance of these gastrointestinal neuroendocrine tumors? Mucosal and submucosal, as I said, they're varying endoscopic appearance, and as listed here. One thing that's often striking is the presence of an endoscopically recognizable vascular pattern, which I think you can see in the bottom right papule, and we'll see some others later on. The other important thing to remember is there's absence of a pit pattern using white light endoscopy, NBI, or on Zoom. And this is important because we should be readily able to distinguish between adenomatous lesions and nets in the vast majority of cases, especially for rectal, and I mentioned this again. Here we've got examples of micropolyposis type presentation with very small little tumors in the gastric body. We've got a polypoid one up here on the right, and then a submucosal type and papule. But there are others as well, and we'll see this later. When we think about gastric neuroendocrine neoplasms, we think about 3 types. 2 of them, type 1 and type 2, are related to endocrine cell hyperplasia leading to tumorlets and then eventually tumor formation due to high gastrin levels. And in the first instance, the high gastrin results from chronic atrophic gastritis or pernicious anemia with pan-gastritis in an atrophic pattern and achlorhydria. The gastrin is high, the pH is high also, and we get single or multiple lesions, especially in the body and the fundus of the stomach. We mentioned about how these are treated. The metastatic risk is relatively low as long as the larger lesions are treated before they invade into the muscularis propria, become T2. As they get larger, the risk increases. Type 2, the hypergastrinemia is secondary to Zollinger-Ellison syndrome in MEN1. It's a specific and quite rare occurrence, but it does occur. And the tumors are usually multiple. The prognosis tends to be a little bit more aggressive, but The prognosis is also related to other tumors that occur as part of MEN1 syndrome, is quite complex. And finally, type 3, this is one that's sporadic. So this is not related at all to hypergastrinemia. The stomach is normal, there's no atrophy, and these are well differentiated or poorly differentiated, usually higher grades, and these tend to have a risk of metastasis is much higher and should be usually dealt with in an oncological manner, although endoscopic resection, as Ulrike will show you later, can be performed in selected cases. So when we have a patient with a gastric NEN, what we have to think of as endoscopists is a careful full endoscopic inspection that will include full insufflation to make sure that you can collapse all of the gastric folds. Think about a bedside pH metry, which is very easy. First gastric juice aspiration, you can see that the pH is high, which will lead you to a direct diagnosis of achlorhydria. You need to biopsy the lesion and the adjacent mucosa, including the antrum and the body, with at least 6. So we think about the atrophy, we think about metaplasia and dysplasia, because these patients also have a risk of both dysplasia and adenomas, I'll mention later. Using NBI and FICE, I find it very useful for characterizing the lesions. With these patients, we also think of biology, antiparietal cell and intrinsic factor antibodies. Thyroid function is often associated with pernicious anemia. CT and other are rarely used unless you've got larger lesions to stage. So getting back to our patient, the patient was found to have a parietal cell antibody positivity. Chromogranin A was 1435, which is classical. High serum gastrin with a low vitamin B12. In fact, it was low normal, but that's definitely low. Intrinsic factor antibody was negative and thyroid function was normal. And the non-involved gastric mucosa showed atrophy, but no intestinal metaplasia or dysplasia. And these are just a sample of some of the slides showing these small little lesions. And this is another example of a classic patient with a small gastric neuroendocrine tumor. We can see that there's complete atrophy of the gastric body mucosa and a small lesion down in the lower part of the stomach that's about 1 centimeter. Looking at European Neuroendocrine Tumor Society guidelines for how to manage these patients, when we get down here to the right, we can see that lesions that are approximately 1 centimeter in stage, if they lift, if they're borderline, you can perform US staging. And if it's safe to proceed that they're T1 lesions, then we can perform either endoscopic resection for the larger lesions that are approaching 1 centimeter or they're approaching a T2 in stage. If we can manage these larger lesions, then other lesions then can be surveyed with endoscopy every 6 to 12 months initially. Going out to 12 to 14 months is what we normally do, most experts in a controlled setting. And we're looking for changes in size of the neuroendocrine tumors, but also looking for any field changes in the background mucosa with the eventual detection of adenomas. So this is a second case of a patient here. It looks like there's gastric folds here, but as I'll show you in a moment, when you insufflate, they all disappear. And this, in fact, is a type 1 gastric neuroendocrine tumor with lesions that are a little bit larger. And as you can see here, when the stomach up in the top right-hand corner in the retroflex view, you can see that the mucosal flow is completely flattened. You've got a large tumor that's approximately 2.5 with other numerous background smaller lesions. When we do an endoscopic ultrasound here, we can clearly see on the right-hand side, it'll come up in a moment. This is a larger lesion. In fact, it's going into the muscularis propria. So it's a T2 lesion. And also you can see just down here some darker lymph nodes. So there were a few lymph nodes as well. So it's not safe to proceed, obviously, with endoscopic resection here. And we can see on the CT scan, as part of staging, the liver was fine, but it's large lesion in the gastric body along the lesser curve. And just adjacent to that is a hypervascular perigastric lymph node. And this was staged using scintigraphy at the time, but normally we do a gallium-68 DOTA PET CT for staging now. And this patient went on to have surgery because it was potentially curative with either a wedge resection or total gastrectomy. Because of the number of lymph nodes in this patient, he had a total gastrectomy showing 3 well-differentiated nets, and the highest T grade was 15%. So again, a little bit more aggressive than the normal ones we see, PT2, PN1, and a background of intestinal metaplasia. So surgery is necessary in selected cases. The endoscopic management of these neuroendocrine neoplasms has been elaborated on very nicely in a recent publication, as I mentioned, and Ulrike will go through that, but just to cite that paper. This is how patients do overall with gastric neuroendocrine tumors, and we can see this all stage progression for cancer-specific survival is about 75% overall. It's 90% if it's just got local stage, but as the tumor becomes more aggressive, when we've got regional stage disease or distant metastasis, the prognosis decreases to 40 and 80% respectively. So they need to be treated with respect. This is a summary showing, in fact, in patients with metastatic, the middle column here with metastatic type 1 gastric neuroendocrine neoplasms, they are related significantly to size of the largest tumor, the tumor grade, and the presence or not of symptoms. Gastrin may also be a factor in predicting metastatic potential, although I don't, in our series that we've had over 100 patients in Dublin, we didn't find gastrin to be a significant factor in some of the patients with malignant type. An important factor, of course, is the depth of invasion, and this really equates to tumor T stage and the size of lesions, and this has been shown in another paper. And we can see here on the right-hand side in the Kaplan-Meier curves that the prognosis, of course, the proportion of patients alive in the presence or absence of local regional lymph nodes changes the outcome considerably. This was a selective resection of type 1 gastric nets and a risk of progression in a study we performed in Dublin. And here we found in surveillance that up to 30% of patients progressed their nets over a 5 to 7 year period, requiring further resection, but it was perfectly manageable to do this endoscopically. Serum gastrin was a little bit higher in these patients, but very much just a fairly barely significant p-value. We also found in this group of patients, interestingly, that there was a dysplasia adenoma to adenocarcinoma sequence of 3.5%. So we found a significant adenoma with high-grade dysplasia or adenocarcinoma in 3.5% of patients with an incidence of 7.59 per 1,000 person years. So I think it's important that we keep this in mind when we're surveying these patients. And this is an example on the left-hand side of the net, on the top and the bottom after resection. And on the right-hand side, this looks a bit more like an adenoma. I think you'd agree at the top with a little bit of a pit pattern. And this was resected, and this was a high-grade, an intramucosal adenocarcinoma, and the patient has done well since. Sporadic, just very briefly, type 3 gastric nets, of course, this is on a background of normal gastric mucosa with no hypochlorhydria. And you can see that this lesion is bigger. It's almost 2 centimeters, and it's touching the muscularis propria here. So it's almost an early T3. In fact, this is what it was at surgery. There was lymph node involvement, and the patient had a partial gastrectomy, as you would for an ordinary gastric adenocarcinoma. These patients tend to have, in fact, higher grade tumors, and they can be mixed with either well-differentiated but higher grades or neuroendocrine carcinomas, and they tend to have far more frequently metastasis, greater than 50% of the time. This is an old paper from Guido Rindi with over 200 patients showing that these type 3 neuroendocrine tumors, or the sporadic types, do less well, and they've got a far higher incidence of metastasis, whether they're well differentiated or whether they're poorly differentiated. Obviously, the poorly differentiated do even more poorly overall, but both need to be treated with caution. Just one slide here on type 2 gastric neuroendocrine tumors, just to show these multiple gastric neuroendocrine tumors as a result of hypergastrinemia in the stomach. Up on the left-hand side, in the bottom left-hand corner, we see the hypertrophic gastric folds that are seen in Zollinger-Ellison syndrome, and that's due to the stimulation. On the right-hand side, we can see then in the duodenum, multiple duodenal neuroendocrine tumors, and obviously they would not be going forward for endoscopic resection. And these are the similar lesions here seen in endoscopic ultrasound staging, but we also have pancreatic up on the right-hand corner, pancreatic neuroendocrine tumors. We've got duodenal neuroendocrine tumors and lymph nodes, and we've also got gastric. So then very briefly then to duodenal. Duodenal neuroendocrine tumors they're the vast majority of time, they're less than 2 centimeters in 90% of cases. They're usually sporadic lesions. They can be associated with gastrinoma, as in the case that I showed you earlier, in sporadic, and they're most often found in the duodenal bulb, and they may occur in the context of hereditary multiple endocrine neoplasia type 1. Another type of duodenal are somatostatinomas. They're fairly rare. They can be associated with neurofibromatosis type 1, but the non-functional ones tend to appear in single lesions. They're often rounded, or sometimes with a lighter or yellow hue or darker red, compared to the surrounding mucosa. They can be firm to touch as well, and they can present as subepithelial type lesions as well. But again, on biopsy, they're usually positive. So it's important to, like in the gastric one, to visually characterize them accurately and determine where they are. Histological specimens, EUS preferable for T and end stage. Think about gastrin and zona duralis, and if you can rule that out, they're likely sporadic, and endoscopic treatment then is probably reasonable. Like as in this case here on the left-hand side, here a single lesion as opposed to the one with MEN1. Some just very brief mention of rectal neuroendocrine neoplasms. They're increasing in frequency, and they're higher in people of color, Black and Asian race, and at least now 50% of them are discovered incidentally. And therefore, if they're discovered incidentally, the majority are being discovered in a non-expert community of general gastroenterologists. We don't have any accurate data on whether they are in where they are preferentially, but I think most of us would sort of see them mostly in the mid to low rectum. The morphology, well, they are distinguishable from adenomas and hyperplastic polyps, as I'll show you in a moment. And about 20% improvement has been noted also in their survival, so that the discovery due to screening has increased probably the likelihood of earlier resection and treatment in these patients. So this is a classical example of a patient that we would see, 51-year-old man. He had a colonoscopy for diarrhea and constipation with an 8mm diameter lesion, 2 centimeters above the dentate line that was hard. The biopsy showed a well-differentiated endocrine neoplasm. The chromogranin A was negative, which is frequent in this case, but synaptophysin was positive. And here you can see a real classical, looks like a small subepithelial lesion, but in actual fact, it's got a vascular trellis on the top with no abnormal pit pattern. So this is classical NET, shouldn't be confused. And this should not be attempted to be cold snare resected or just simple polypectomy. This will leave some of the tumor in place, and it needs to be done with a modified EMR, as we'll see later on in the elegant slides by Ulrike. So this had an endoscopic ultrasound. Again, it's within the mucosa and the submucosa. Muscularis propria here is fine. So this is a T1 lesion close to the muscularis, but this is resected and fully resected using a modified EMR technique. We did also do somatostatin scintigraphy to make sure there was nothing in the liver or any downstaging or lesions downstream. I'm not going to go through this in detail, but this is the ENET's consensus guidelines for colorectal neuroendocrine neoplasms, its treatment algorithm, and basically for smaller lesions, the one on the left-hand side that we're thinking about for endoscopic resection, we're thinking that we can resect these if they're T1 lesions, if they're safe to resect, and we'll see the techniques to do this after staging with endoscopic ultrasound. And if they are T1s, it's safe to go along and do this. There are a small number of rectal neoplasms that are aggressive for small size, and we might come back to that later. For the larger ones, of course, and any risk of T2 lesions or any risk of nodal disease, of course, we're thinking about endoscopic resection is not going to be adequate, and we're thinking about more aggressive and surgical resection. These are an example of a few rectal neuroendocrine tumors, how they can present differently. The one in the middle with sort of a red cap on the top of it in a polypoid manner. We've got a sort of looks like almost like a subcutaneous and yellow firm nodule on this one here in the retro view. Another small little dimple with sort of vascular trellis on the bottom left-hand corner. And the one is with this umbilicated central portion. This is one you should be very cautious with because it very often harbors more aggressive nature, as was in the case in this patient who had 2 perirectal lymph nodes, and this polypoid one. But once again, you can see on the bottom right-hand corner, there's no abnormal pit pattern in these, and that should really alert the endoscopist to the fact that it's not hyperplastic or it's not, in fact, adenomatous. Treatment for rectal nets then should be is based on size, because the metastatic risk increases as the size increases. Very little metastatic risk for patients with tumors less than a centimeter, and usually, and then this exponentially increase with increasing size. However, for some small lesions, some authors have said 10% of small tumors can harbor aggressive disease, and with that in mind, we think about lymphatic invasion or lymphovascular invasion, and they're definitely factors that are involved in poor prognostic outcomes. And that's why it's important to discuss patients if any doubts at the neuroendocrine tumor multidisciplinary team meeting. Finally, then, small intestinal and colonic. Small intestinal NENs, they can be seen in the terminal ileum, but as most of the NET experts will tell you, even very small ileal neuroendocrine tumors, and sometimes jejunal, can present with metastatic disease, and therefore endoscopic resection is not usually recommended in these cases. Similarly, for colonic NETs, when they're purely colonic, the risk of metastatic disease is also higher. They're usually found in the right and transverse colon, and they can be mixed with adenocarcinomas as well. And once again, the metastatic risk will be related to the aggressivity. They're often higher grade type tumors. So one, I would recommend discussion at the multidisciplinary team. So in summary then, gastrointestinal NENs, different from that of adenomatous or hyperplastic lesions, and need to be increasingly recognized. Standard pathology is very important, but beware of proliferated and higher grade neuroendocrine neoplasms or neuroendocrine carcinomas. Use of standardized reporting templates will come online, and I think this will be useful to remind us of the different biological behaviors, but also helping us to plan therapy and send on for referral. Additional staging procedures in some cases is important, especially for endoscopic ultrasound, for larger gastric, duodenal, and rectal NENs. And don't forget to think of gallium somatostatin receptor PET-CT imaging. And finally, seek out your NET MDT opinion by the Center of Excellence Group. And I'd like to thank you very much for your attention.
Thank you, Dermot. Thank you very much. Wonderful presentation with very clear ideas. It's evident it's very important to characterize the neoplastic features of the lesion and the surrounding mucosa with biopsies. So it's very important. So from my English, I think it's much better to use the term neoplasm instead of tumors. So I think. So now we have to move to the next presentations. Is the turn of Ulrike Denzer. Ulrike, she's going to talk about the endoscopic management of gastrointestinal neuroendocrine tumors. Ulrike, she is the head of the endoscopy unit and professor. She's based in Marburg. He works at the University Clinic, University Clinic Hospital. So now your turn, Ulrike, the floor is yours.
Yeah, hello. Thank you for the opportunity to talk about the endoscopic management of GI tract NETs in the following 15 minutes. So I start. Yes, these are my disclosures, nothing very important for this topic. So I will organize my presentation according to the following topics: endoscopic management of gastric, duodenal, and colorectal NETs, and pancreas NET as a separate entity, and therefore we have excluded it here. So you know this table already. We distinguish between different gastric NET types, with only NET types 1, 2, 3 being considered for endoscopic resection. Type 4 is already a malign tumor with mostly G3 grading and a high risk of metastasis, and will requiring oncological surgery in every way. Type 1 is associated with chronic atrophic gastritis and has the lowest malign risk, and lesions are often small and multiple. Type 2 is associated with Menn syndrome or Zollinger-Ellison syndrome, and metastatic risk is up to 30%. And type 3 occurs solitary with mostly G1 or G2 grading. Metastatic risk can nevertheless be up between 50 and 100%, and we have a higher tumor mortality. So according to the international guidelines, here you see the ESGE recommendation. Type 1 should be resected endoscopically if the size exceeds 10 millimeters. An analysis of 15 studies examined different endoscopic resection data in type 1 GNETs. And there was a local recurrence of varying extent between 0 and 60%. The 60% were seen mostly in snare polypectomy, but no tumor-induced mortality. And there is little structured data on type 2. So patients with type 2 should be referred and treated in multidisciplinary NEN settings in centers. And type 3 can be resected endoscopically up to a size of 1 or 2 centimeters. And an analysis of the available studies showed that with a size up to 2 centimeters, the tumors were mostly well differentiated, and a complete resection was possible at up to about 80%, 87%. And during the follow-up, only one patient with the G2 grading developed the metastasis. Therefore, endoscopic resection seemed to be sufficient in a low-risk status. In low-risk status is no lymphovascular invasion and no deep invasion, especially T2. What can we do? Which resection technique are available, and which are the ones we should use? One resection technique we all know is the endoscopic mucosal resection. This is usually performed in a modified form. That means either as a cut-assisted EMR, or for example, band ligation EMR, or EMR after incision as an ESD. This is more favorable, especially in the stomach or duodenum, than the poor snare EMR, since the lesion can be sucked in. Additionally, after the injection, and you see that in this case, the lesion is sucked in and cutted, then we take it out for histology workup, and afterwards we do inspection of the resection site, like in this case. So another resection option is the ESD technique, which is especially useful in high-risk NENs, in singular and larger NENs, as this type 3 type here, which was really a high-risk NET. Normally we had resected it oncologically by surgery, but in this patient, she was not a real good candidate for that, and so we did ESD. And here you see the ESD preparation. The tumor is very well vascularized, and afterwards the last cut is done with the IT knife, and then we have a look onto the resection site. It was a complete resection, but it was already a G3 situation. Another newer technology is the endoscopic full thickness resection device, which is now available for the upper and lower GI tract. And the initial data are already available for duodenum and colorectum, and I show examples later. Which resection procedure should be done for which lesion in the stomach? There we have no comparative prospective data. ESD, there is a case series showing that ESD of gastric nets allows a high rate of complete resection. There are some retrospective studies comparing EMR and ESD for gastric nets. They show that type 1 nets up to 10 millimeter can be safely resected by the endoscopic mucosal resection. Retrospective comparison here showed no difference in this regard. And for lesions up to 2 centimeter, the ESD was superior in terms of complete resection, but this had no real influence on the recurrence rate. We should not do the resection by conventional snare polybectomy. This showed a higher recurrence rate in the stomach. And for the endoscopic fully resection device, there are only single case reports available for the gastric net. For this reason, the resection procedure can be chosen for gastric nets depending on size and risk profile, and ESD and endoscopic full thickness resection seem reasonable for larger lesions with higher risk of lymphovascular invasion or a higher grading. So I will go to the non-ampullary duodenal net. Here, the ESG guideline suggests the resection of non-ampullary duodenal nets up to 15 millimeters in size, except gastrinomas, as Dermot O'Toole has mentioned before. These lesions are mostly asymptomatic incidental findings. Therefore, studies have shown that we can resect a well-differentiated duodenal nets up to 1 centimeter in size with a high complete resection rate and no recurrences. But a study, a bigger case series has shown that except for the size, risk factors for metastasis in this type of lesions were the size of more than up to 2 centimeters or more than 2 centimeters, and lymphovascular invasion, multiple tumors, and G2 grade. I have to go back once. That was too fast. Yeah. This is an example of a net in the duodenal bulb of about 10 millimeters. This net was resected by a CAP-assisted EMR. I wanted to show you the endo-ultrasound picture, but this doesn't work now. Now it's coming. The CAP-assisted EMR was done like previously shown, and we do endo-ultrasound in this case before resection. And here you can see size of the lesion. You can measure it precisely, and you can investigate the wall layer localization of the tumor. This can be well visualized. The tumor was then afterwards resected completely. It was well differentiated, and the resection margins were okay. So now this is another case. It's very similar. It's a well differentiated net in the duodenal bulb, resected with a CAP-assisted EMR. And you see here, after injection, we had to suck in the lesion, and we had to cut a very long time. This is a sign for a more fibrotic tumor. It was resected, taking out the resection site. Looks not bad, quite complete, but the margins were positive. Here we have to think about what to doing with these lesions. Because the tumor was well differentiated, we decided to do a follow-up. The first follow-up after 3 months is negative now. With endo-ultrasound, we do the follow-up and local biopsies. We can discuss this perhaps later. Here's another case, somewhat a little bit more atypical, net in the second part of the duodenum, completely resected using the EMR technique. And the next case presented as a lesion in the second part of the duodenum that was non-lifting, turned to be out to be a neuroendocrine tumor. And we resected it using the endoscopic full thickness resection device. Before that, we looked where the papilla is. It's necessary to to prevent for complications, to investigate patients already with the duodenoscope. In the preliminary examination, the tumor could be resected in total, and it was a well differentiated, not T2 tumor. It was already in only T1 tumor, and the patient went to follow up. Which resection data techniques are sufficient for the non-ampullary duodenal net? Concerning the data, there's a meta-analysis of 8 studies comparing surgical and endoscopic resection. Here, the endoscopic resection resulted in more frequent positive resection margins of the specimen. However, we have no long-term data on local recurrence, showing us what impact this is in well-differentiated tumors. ESD, there are only small case series with a high perforation rate. ESD offers the higher rate of complete resection, but it's especially in the duodenum technically challenging because of the thin duodenal wall, and should be referred to really expert centers. And then we have the endoscopic full thickness resection. There are initial data on the first cut then close technique. I don't show here. These are most data from the Far Eastern, and then the data for the FTLD system. We already know there are some case series, mostly mixed, including adenomas and other lesions. But probably this is reasonable for non-lifting, complicated, small neuroendocrine neoplasms. Finally, the most common colorectal nets that go to the rectal nets now are found in the rectum, and they have a favorable risk profile. Therefore, endoscopic resection up to 20 millimeter is possible here. A big cohort study analyzed rectal nets after endoscopic resection over almost a follow-up of 12 years. And almost all were well-differentiated nets. Metastasis occurred only in 1% after 6 years, all in G2 tumors. And this data show that we have to do a long time follow-up in these patients if we resect them. But therefore, it's endoscopic resection of small rectal nets are the first choice of treatment. And it's possible to do it with a high complete resection rate. But which resection technique should we take here? We already have the modified endoscopic mucosal resection technique we talked about. Here are some meta-analyses that show that this modified EMR is superior to conventional EMR. Meta-analysis of 11 studies. So we should not resect them using conventional snare polypectomy, hot or cold. And there are some data in a meta-analysis comparing ESD to modified EMR in smaller lesions. Here the cutoff was 16 millimeters, showing that the complete resection rate is comparable. But in bigger lesions, I think I prefer to do ESD or to use the endoscopic full thickness resection device. Here is one example of an ESD of a rectal net. It's a really small rectal net. Here, after circumferential incision is done, and then afterwards preparation. And this is the circumferential incision. Afterwards, dissection takes place. Even in this small lesion, we have a more time-consuming investigation doing ESD. That's clear. For this lesion, we needed about 35 minutes in total. And here we do further dissection. And afterwards, we have the last final cut doing the complete resection. But probably it seems more effective for a little bit bigger lesions between 16 millimeters and 2 centimeters. But we have honestly to say that comparative data and clear prospective data for this question are lacking. So the last cut is done now, and the complete specimen can be removed, and we have a look on the resection side. So the last technique we have to talk about is the endoscopic full thickness resection in the rectum. And the ESG guideline does not recommend it of using for rectal nets. I think meanwhile, it has become part of our daily routine, especially after previous incomplete, accidentally snare or forceps resection of nets. We have here some data from the German FTID registry. They analyzed 14 cases with a high complete resection rate. The method is also technically well applicable in the rectum. Another retrospective comparison compared the surgical TEM and the endoscopic full thickness resection, and this resulted in no differences in the outcome and showed a shorter procedure time of the EFTR. And here you see in this example that the rectal net can be easily removed using the full thickness resection technique. And we have a definitive staging histopathologically of the raceme, of the histological of the resected specimen. So I want to conclude. Endoscopic resection is possible in gastric net, duodenal net, and rectal net, up to 1 to 2 centimeters, and it depends on the risk profile of the lesion. And the endoscopic resection techniques are the modified EMR technique, the ESD, and the endoscopic full resection device technique. The base for the small resection is the modified EMR technique. We should not do snare polypectomy in most cases. The application of the ESD and the endoscopic full thickness resection device depends on the localization and the risk profile of the lesion. And now I want to conclude with that, and I want to close and we can go into discussion.
Thank you, Ulrike. Fantastic presentation, wonderful presentation. I think the management of patients with neuroendocrine tumors is controversial. We have to take decisions about the follow-up protocol, to tissue acquisition, to type of resection technique. We have different resection techniques. So a patient with positive margin, with complete resection, we have a large number of questions. I think we have 10 minutes to answer all of them. I am trying to summarize because we have many questions. So most questions are related to if with the recent advantages we have with the endoscopic techniques, if we can replace the tissue acquisition, for example, with the future artificial intelligence, with the use of the enhancement techniques to help do endoscopic ultrasound. Do you think we should remain to obtain tissue acquisition or not? What do you think?
I can imagine that we will use artificial intelligence in the future for detection and, for example, for classification of these lesions, because in the rectum they are very typical of the appearance, with a little bit yellow, a little bit vascularized, but not like an adenoma. I can imagine that we can use that. In the stomach, probably either. It's a little bit more difficult in the multiple lesions in the stomach in type 1, but that's a good way. I don't know if we can use it always artificial intelligence in endoscopic ultrasound, but it's a little bit like investigating subepithelial lesions.
Okay, I think the same. We have more questions. So more questions are related if we find lesions, should we take biopsy prior to resection, or we should resect this lesion? What do you think? Oh, Dermot, Ulrich, what do you think?
Well, yeah, I answered one of those online. I mean, one of the questions was from a colleague who said that maybe they didn't have endoscopic ultrasound and they were worried about biopsying. I think for small gastric lesions, we always think about maybe rendering something not resectable. I think it's safe to biopsy a small to medium lesion, 1 or 2 biopsies or 3 biopsies, it's fine. When you're on the middle of the lesion, you almost always get the answer. And one of the other questions, I think, Vincente, that I saw was, when do we need to do fine needle aspiration biopsy or FNB? In my opinion, it's almost never, you almost never have to do that for lesions of the stomach or the rectum or the duodenum. I've never had to do that because you always get it from the mucosal biopsies. And we reserve the fine needle aspiration biopsy on an endoscopic ultrasound for pancreatic or for lesions outside. But, you know, sometimes they're in between lesions. There's a lot of it submucosally. So why not? I mean, there's always an exception to the rule. But to answer the question, you know, 2 or 3 biopsies centered on the lesion, whether they're small to medium, it's fine. And it doesn't really interfere with full resection after that, because we're using modified EMR techniques, at least in the stomach or in the rectum. So I think it's safe to do it like that.
Okay, more questions. I think regarding the patients, for example, sometimes it's very important to recognize these lesions. So sometimes, for example, in rectum, we detect a small lesion and we thinking they are a protostic lesion. We perform resection with cold snare and we find positive margins. So in this situation, what should we do? To repeat the colonoscopy, taking biopsies, perform full thickness resection, to resect the full scar? What do you think?
I looked over our data of endoscopic full thickness resection yesterday with my colleague, and we did already 11 endoscopic full thickness resection with NET indication, and most of these indications were referrals after incomplete resection.
Okay.
So we had to identify the scar or the residual parts of the rectal nets, and then we do this endoscopic full thickness resection, because we can resect all together. The patient has the whole histopathological information, and we can say, okay, it's all out, and you can relax.
Okay.
I can maybe just comment as well, Vincente. This is a common occurrence as well with us, but I think that we can't forget the good quality colorectal surgeon here as well. So the important thing for our colleagues who are tuned in is that if we get the biopsy and it's net, you need to go back, the same endoscopist, to identify the scar, to mark the scar, and then we can go back and resect that using a transanal microscopic surgery or endoscopic full thickness resection, whatever the resection, as long as it's complete. But the big problem at the outset is to avoid falling into this trap of incomplete resection. That's the message we need to get out there, and to identify exactly. So if we have a little tattoo, it's really useful, I think.
Okay. More question. Do you think, is there a role for band ligation without resecting? For example, if we find lesions in the stomach, smooth lesions, can we perform band ligation without resecting or not? Or it's much better to obtain histology? That's a good question, yeah. But
there were some data concerning with that band ligation. It's like ligate and let go this way. But then we have no histology. I don't prefer that.
Yeah.
Me neither. I think that, and also band ligation like that, if you do it sort of a lot, you will have complications from it. There's no doubt. I mean, by nature. So I think it's better, you're better to know what you're dealing with. So if you've got a gastric net and you're thinking between a type 1 and even a type 3, if you go to the ENETS now, the algorithm that we use, you will see that you need to do biopsies from the other part of the stomach as well to make sure there's no atrophy, etc. So I think you can make a plan for the patient, because it's not just one-stop shop. What you need to do is have a plan for the patient down the line, so you know you're dealing with a type 1, pernicious anemia, hypergastrinemia, atrophic gastritis, etc., because that patient will then have a protocol for them for life, including their treatment with B12, with all of the other things as well. Or a type 3 net, you know that you have to be thinking about other forms of treatment. So I think it's really important to have the protocol there to help us along, rather than just ligating everything you see.
Okay, more questions. Do you think the bite on bite technique to obtain biopsies or the mucosal incision assisted biopsies can difficult posterior resecting, or is not important?
Some people say that biopsy then we can have difficulties to resect completely, but I don't think so. I think it's not necessary to do many biopsies on nets. Normally we can do 1 or 2 biopsies, and then we have the diagnosis, because it's not a subepithelial lesion. It's always growing from mucosa to submucosa, and we get the diagnosis with 1 or 2 biopsies. It's not necessary to do multiple biopsies.
Okay. One question regarding diagnosis. Do always we need endoscopic ultrasound in all situations, or in which situation we should not, the endoscopic ultrasound is not necessary?
Okay, so endoscopic ultrasound, I think for the smaller lesions, and I saw some questions as well, for tiny things like less than 5 millimeters, etc., where we've got tumorlets, for example, in type 1 gastric neuroendocrine neoplasms, that we don't usually do. I tend to do them for ones that are going to be resected, like borderline, or even for larger ones, because that's part of the staging. So if, for example, we've got a 2 centimeter type 3 sporadic gastric net, I will tend to do an endoscopic ultrasound because I'm doing it at the same time. You could also say the same thing for larger ones of the rectum, but we're still going to do an MRI pelvis for staging, and we're going to do a gallium-68 DOTA TOC, tape, or NOC PET CT as well for staging. But because I'm doing it, I usually combine both, so it's easy to do both. So I think that EUS is for, yes, potentially resectable, but we don't need to do EUS all of the time for small lesions that follow up. That's overkill. I think it's not necessary. Maybe Ulrike, you have a comment.
Yeah, and I think we should do it for duodenal lesions in every case, because here it is very important how to manage, and we have to know that it's a low risk situation if we take them out. And in the case I mentioned, we have these positive resection margins, but it's well differentiated, and we have to think about the patient's next plan, and then we have to have a complete staging before resection.
Okay, thank you so much. Unfortunately, I think we have no more time. I think the time is over. Thank you so much, Ulrich. Thank you so much, Dermot, for your fantastic presentation. I think these neuroendocrine tumors are less frequent than other malignancies, but they are not as rare as we think. So this information, diagnosis and management is very important. So I hope all of you have enjoyed with this seminar. So let me 2 minutes to final remarks. Take in mind the ESG days is coming soon. So remember the deadline to the registration is April the 12th. ESG days is a very international event with faculties from many countries, scientific societies, 1 full day live endoscopy, many concurrent sessions and training sessions. So you remember you can join to the ESG. If you are member to if you join to the ESGE, to this family, you can have many benefits. For example, fellowship, research grants, participation in guidelines, and much more. You can be member of our ESG family through our dual membership program with a special discount, and you can join us. And remember, take in mind our next webinar will take place on May 18 after ESG days, ESG video live endoscopy from London, assessment and management of biliary strictures. So take in mind this data. And finally, thanks to obviously to webinar team, David Tinker and Gabi Barkas, and also the rest of the ESG governing board. Thank you so much. Bye. Good night.
Thank you so much. Bye, everybody. Thank you.